Hi, I'm Juanjo Zafra, emergency physician from Bilbao, San Hospital, North Spain. And the ultrasound leader who is with us today is Giovanni Volpicelli.
Hello.
Épica Podcast, Ecografía a pie de cama, con Juanjo Zafra y Enrique Ortiz, desde EcoSemes, Euskadi.
Hi Giovanni, you look fine.
I'm okay, very busy, but okay.
Where do you work, Giovanni?
The name is San Luigi Gonzaga University Hospital in Torino. Now we have something like 70 patients admitted in my hospital.
The main question, CT scan or LAN ultrasound?
There is no question. I mean, of course, our experience is that when we started seeing patients with COVID-19, we started doing CAT scan. But then, after I may say 1-2 days, it became totally impossible because the number of patients you have in the emergency department in the same time arriving with symptoms suspected for COVID-19 is so huge. And also it becomes so dangerous to bring patients around in the hospital, in the radiology department and so on, that you will shift automatically to lung ultrasound because it is practical, it is very sensitive, and of course, it gives much less problems of cross-infections in the hospital. So there is no question. We only use CAT scan in complex cases when, for instance, the diagnosis is not defined, and we need to be sure about what is going on in the patients. For instance, in chronic patients with other diseases, chronic diseases of the lung, sometimes it's not possible to distinguish what is due to the acute infection and what is chronic. In these patients, sometimes we use CAT scan, but most of our patients, we don't perform CAT scan.
In your opinion, with your experience, is LAN ultrasound compatible with personal protective case, the security equipment?
Of course, totally compatible. There is nothing special you need to do in the ordinary work in the emergency department. I mean, when you visit a patient, for instance, with mild symptoms or even in oxygen, in supplemental oxygen, there is nothing special to do. I mean, what we use it more is just we covered the keyboard with a transparent film to avoid the direct contact with the keyboard. That is the most sensitive part because, it's not regular, the surface, and so it's more sensitive. Then we use the probe regularly, and what we do, we clean with particular care, of course, but this is something that we do always, with alcoholic solution after the exam. And we use different gloves to make the exam, to clean the probe, and then to remove our protection. So we use 3 pair of gloves, and this is the best way to maintain asepsis between one patient and the other. The problem is more when you use lung ultrasound to assess or to monitor patients. In the meantime, there is an invasive procedure, like, for instance, intubation or bronchoscopy or something that may make aerosol in the air. So in this case, we have a procedure after the exam to clean up the entire machine. So we remove the plastic covering the keyboard, and we clean all the rest of the machine, the screen, and so on. But usually when there are no procedures going on, you just need to clean up the probe. The point is that when you take the machine, you must be sure that someone cleaned it before you use the machine. So for this reason, it is more convenient to clean again the machine anyway. So before the exam and after the exam, but nothing more.
Giovanni, I'm going to ask you about ultrasound findings that could be specific for this disease. I know you prefer not to answer, but I would like to hear your opinion.
No, I want to be honest. I'm working hard to prepare a communication in form of an article or something similar to have what I'm watching in these days is many persons talking and showing videos and writing about lung ultrasound in COVID-19. In my opinion, without having a very strong direct experience on patients. That is not a good service for lung ultrasound. Yeah. So what I wanted was just to accumulate experience, to see patients, and just only now we are ready to communicate what is our experience. And I want to do in some authoritative channel to be, to give a strong voice about that. And I don't want to anticipate. Anyway, it is very simple because lung ultrasound gives what we expect from a viral infection. So we have B lines, of course, many, because they are the sign of the interstitial involvement, consolidations, irregularity of the pleural line. These are the three main basic signs of the disease. The point is that the combination of all these signs and especially the distribution in the lung of these signs is very specific of the disease, or at least it is very specific of a viral disease. Then I can say that I saw many aspects that are very specific, even to distinguish this very strange disease that we never saw before from other kind of viral infections of the lung. And I have some idea about that, and we are testing this idea in our patients. What we are doing is just collecting videos from our patients and then revisiting the videos to see how much these signs are specific or not in our patients, and also how much sensitive they are.
What is the ultrasound role about triage, about patients' classification?
I must say that we are using lung ultrasound for three different steps. The first step, that is the crucial step, in my opinion, is the most important, is the triage. In triage, lung ultrasound is useful because what we do is just observing if there is the characteristic pattern of the infection, pneumonia. And this has a great powerful. When I talk with my colleagues performing lung ultrasound, what we say, all of us, we say, I know that this patient has COVID-19 just when I put the probe in the lung of this patient. The problem is to standardize this impression and to give a rule to this impression. It's not easy. But the general impression is that lung ultrasound is so sensitive and very specific in identifying persons with pneumonia from COVID-19. In triage, this is very useful because when you will have the outbreak of patients coming all together in the emergency department, it is very useful to orientate the flow of these patients. So deciding who is the one who needs to be isolated, who is the one who needs to be just discharged home without any sign of pneumonia, and who is the one that probably will worsen the situation, will go towards acute and severe respiratory failure. Then we use these rules to decide also admission to the hospital. So in which department to admit the patient, considering ICU, that is totally dedicated to COVID-19, the emergency department, totally dedicated to COVID-19, but also ordinary wards. They have split separate areas for COVID-19 patients and normal patients. So you need exactly from the emergency department where to admit the patient, and not always is necessary to wait for the response from the test, from the PCR test. And this is very crucial. Yes, distribution of the pattern is one of the main criteria we use. But it's not enough, because it is very important to correlate the severity of the pattern with the condition of the patient, like we do for other use of lung ultrasound that we do in ordinary diseases. So this is very important because while it is common that we see patients with very mild symptoms, but already signs of pneumonia in the lung, it is very common, and the negative chest radiography, this is something that we are observing, is very common. It is not possible, the opposite. So it is not possible to see patients with acute respiratory failure, severe, without lung ultrasound signs, or with mild, just mild lung ultrasound signs. So this is something that gives more specificity to lung ultrasound. In some way, it is very similar to what we observe in pulmonary edema. When you have cardiogenic pulmonary edema, and the patient, when you suspect cardiogenic pulmonary edema, and the patient is in severe distress, respiratory distress, it is not possible to observe B lines only in some part of the lung. You need to observe B lines everywhere. Otherwise, it's not pulmonary edema. So it's something similar.
Would you dare to share your opinion about if there is a correlation between ultrasound patterns and patient prognosis?
And this is the second application that we do for lung ultrasound, that is quantification. So what we do is quantification of the lung lesions. Our idea is that quantification may be correlated with need for intubation and worse prognosis. But there are no data showing that. Of course, we use a kind of quantification that is not the usual one, because in my opinion, in the first examination of the patient, you need something that's a technique that is very simple, very immediate. And our effort is to create a technique that is very easy to perform at bedside in the first examination of the patient. My impression is that maybe there is no correlation with the severity of the lung involvement, because I saw too many patients worsening in a few days, starting from a very mild situation, and many patients, on the contrary, going very well, even if at the beginning they had a very bad situation of the lung. So my general impression is that there is no correlation, but we will see. The Chinese, for instance, in the studies with CAT scan, they showed that the more the surface of the lung is involved, the more the patient goes towards invasive ventilation and respiratory distress. We will see. We have not enough data to say that.
Oh, then what are the most important findings to check on monitoring to avoid to get worse?
And this is the third application that we do of lung ultrasound, that is monitoring. This is mainly done in the ICU, in patients ventilated. but also in the emergency department in severe situations when the patient is not intubated, but it receives CPAP ventilation. In these patients, what we do is we check every day the situation of the lung to observe the effect of ventilation. And also we use the regional distribution of the lesions to indicate the need for recruitment maneuvers, for instance, like pronation or something else. In this case, we use a technique that is the classic technique, that is the 6 areas per site with the scoring given to B lines, coalescent B lines, and consolidations. This is published by the French group in the journals that we know.
About the recovery, do you know if there is a chronological order of these findings, that it means the patient is getting better?
I don't think there is. Listen, this disease, in my opinion, for my observation, of course, maybe I'm wrong, but this disease is totally crazy. Totally crazy. The evolution of the disease is crazy. There is no rule. I think also the pulmonary lesions are crazy. There is no rule. I saw many patients with consolidations going very well and recruiting in a few hours. Maybe these consolidations are just atelectasis, peripheral atelectasis, we don't know. And patients without consolidations, just interstitial patterns, going very bad, going to intubation and even dying. So I think there is no rule. And this is the reason why I think, in my opinion, the scoring and the quantification should follow different rules than the ordinary RDS situations that we know.
Do you think it could be important in these patients to add posterior areas on the study protocol? Are they important?
Posterior involvement is important because it's the indication that maybe you can treat the patient with pronation, for instance, and to favor the recruitment in the posterior lung. But I don't see any different indication. So I don't think, but maybe I'm wrong, I don't think this indicates prognosis of the patient more than other aspects.
Is there any correlation with the pleural thickening? In fact, it isn't a concept joined the consensus conference, is it?
First, the terminology is not correct because we don't assess by lung ultrasound the thickening of the pleura. This is done by CAT scan, but it's not possible by lung ultrasound because the pleural image in ultrasound is just an artifact. You can measure the thickness, but you measure just an artifact, and there is no correlation with the real anatomic structure of the pleura. What we observe in lung ultrasound is the irregularity of the pleural line, and this is the correct terminology. It is true that the irregularity of the pleural line was not mentioned in the well, it is mentioned, but it's not a specific sign. But you must understand that the irregularity of the pleural line is nothing else than an adjunctive sign of interstitial pattern. So when you have irregularity of the pleural line, you have B lines, of course. So it's just an accompanying sign of interstitial syndrome together with B lines. The point is that you may have the interstitial involvement in the periphery without irregularity of the pleural line that we observe many, many times, and I think it's very peculiar of this disease. But you cannot have interstitial involvement without B lines. This is the reason why the irregularity of the pleural line is much less important than B lines.
Okay, about this. When will we get the second consensus conference?
I think this outbreak just stopped everything outside COVID-19. So now the whole world is working on the COVID-19 and ultrasound, especially because as you know, ultrasound is so crucial in this disease, in this epidemic. So I think we will start again talking about the update of the consensus conference after this pandemic, when everything will be again coming back to normality. With something more, because we will have more knowledge about lung ultrasound, because this disease is it seems to be done just for lung ultrasound. It seems to be something that needs lung ultrasound more than other diseases. So we will have more knowledge, and of course we will have also more spread acknowledgement about the usefulness and the efficiency of lung ultrasound in the world. What I'm observing now is that any colleague carrying COVID-19 is starting using lung ultrasound, is starting asking to others how to learn lung ultrasound. So I think after this disease, the use of lung ultrasound will be much more spread than before.
How often did you find patients with ultrasound heart issues, like precardial fusions?
No, I never found effusion in my patients. Just in some patients, very few, some small pleural effusion, usually bilateral. But of course, my main experience is in the first diagnosis of patients. Maybe in the ICU, in the ICU, we perform echocardiographic monitoring, of course, in these patients, like for any critical ill patient. But I don't see any specific pattern that may be of interest in this disease. What I can say is that sometimes we see cross-infections with other virus and bacterial sobreinfection. So maybe these patients have also this problem. Some patients have also this problem.
How could a physician discriminate between bacterial pneumonia and viral pneumonia?
When we observe isolated large lobar consolidation with a bronchogram and effusion, this is not COVID-19. This is bacterial. Of course, in many patients, we saw cross-infection, cross-bacterial infection. And these patients have also, together with all the specific alterations of the interstitium, they have also consolidations due to pneumonia, bacterial pneumonia. So what we do is that in these patients, when we have the suspicion of a bacterial sobreinfection, we use procalcitonin. That is very useful to decide to put also antibiotic treatment in these patients.
Legionella, pneumococcal, and mycoplasma antigens in urine?
And also for differential diagnosis, we perform the blood test for pneumococcal and for Legionella and mycoplasma. We saw some cases of mycoplasma that was not easy to distinguish. So when you have the doubt, you perform the antigen.
Okay, about learning, and this is the last question. All of us know how ultrasound works, and also the audience, of course. But for someone who doesn't know how to use ultrasound, do you think a lesson of 15 minutes would be enough?
No, of course it is not. Anyway, I am, for instance, in my hospital, I'm encouraging my colleagues to use ultrasound using a standard technique and recording videos. So if you have in the hospital the possibility to learn at least how to perform ultrasound, that is not that difficult, and recording videos and making an archive of videos of cases, you may have in a second moment the possibility to have an expert revisiting the videos and helping you in the diagnosis and even to understand the patterns and how they work and so on. Now I'm going to have my night shift in the hospital, and my colleagues called me saying I put the videos of these patients in this part of the computer. So during my night shift, I will revise all the videos. And this is a possibility. Of course, to become expert in ultrasound, you need practice, but it's not that difficult, we know.
Okay, and finally, do you want to add something to the world audience?
No, just to be alert, to prepare the hospital, because it's the most important point. Preparing the hospitals means preparing the spaces for the patients, being prepared to dedicate the hospital, most of the hospital, to this disease, because the outbreak, when it arrives, it's very dangerous and very busy. So places for the patients will be not enough in the ordinary hospitals. And we also opened a new area for intensive care. We asked for more ventilators. We asked for more oxygen points. We asked for more CPAP devices. And also we totally dedicated to COVID-19 other wards. The ordinary wards and the emergency medicine ward is totally dedicated. So the hospital become hospitals dedicated to COVID-19. This is what happens during the outbreak. And the problem is that other diseases still are coming to the hospital. So it's a mess. And of course, implementation with lung ultrasound is crucial, as I already said.
Thank you a lot, Giovanni, for being on Epica Podcast, our ultrasound channel in Spanish, for sharing your time and your knowledge to improve the ultrasound management in this kind of patients.
Thank you.
Thank you very much.
Okay. Ciao, ciao. Sorry, I didn't understand the question.